Hello, everyone. I hope you can hear us and also see us. My name is Bianca Berezovski-Raluca. I'm the Journalist Relations Specialist of IJERP, and I will be the host of today's webinar entitled Sleep-Related Phenotypes, Future Directions for Insomnia, ADHD, Restless Sleep Disorders in Childhood. Maybe we can wait another minute just to let everyone join us. And we will start with a short presentation of MDPI and our speakers, and then we will start to the webinar. We will let our speaker present the topics. I will begin with a short presentation of MDPI. MDPI being the organizer of this webinar, actually a pioneer in scholarly open access publishing, and I want to emphasize the fact that MDPI has supported the academic communities since 1996. Based in Basel, Switzerland, MDPI has the mission to foster open scientific exchange in all forms across all disciplines all over the world. Our journals, open access journals, including 418 peer-reviewed journals and 9 conference journals, are supported by more than 150,000 academic experts who share our mission, values, and commitment to providing high-quality services for all researchers and authors in academia. The 2 journals that organized today's webinars are International Journal of Environmental Research and Public Health. It is an interdisciplinary peer-reviewed open access journal published semi-monthly online by MDPI, and it covers environmental sciences and engineering, public health, environmental health, occupational hygiene, health economic and global health research, and not only. And also the journal Children, in international peer-reviewed open access journals as well of pediatrics, focusing on the dissemination of clinical, epidemiological, and transitional science that is relevant to children's health, published monthly online by MDPI. More information about these journals and how you can publish your papers can be found on each journal online web page. So today, speakers are Professor Dr. Karen Sprout. It's the chair of this webinar. She will start with a short introduction. After that, we will continue with Professor Dr. Ludra Del Rosso. After that, Professor Dr. Silvia Milano will speak about the sleep phenotypes in ADHD. And we will continue with Professor Dr. Oliviero Bruni. We will end with a Q&A session and a short closing by Professor Karen Sprout, the chair of the webinar. During the presentations, if you will have questions, please feel free to address them in the Q&A section of Zoom. Also, in the Q&A session, if you want to address the questions, please raise your hand and we will let you address the question, and our speakers will answer. The topical collection that is that organized this webinar is the topical collection organized between the 2 journals that I mentioned before, IJERP and Children, entitled Sleep in Children, and the editors of this collection are Professor Dr. Karen Sprout and Professor Dr. Patricia Peirano. Also, you can find online the webpage of this topical collection on each journal webpage. I will start with a short presentation of our chair, Dr. Professor Karen Sprout. It's a full professor. She's a full professor at the University of Paris, neurodirectorate in CERM institution. Her expertise in teaching neuropsychology, subdiscipline and statistics has allowed her to interact with multidisciplinary research teams and also to perform translational research in her domain of interest as developmental neuropsychology and somnopathology. She also investigates the impact of sleep on childhood performance and health. She has been researching and lecturing in the field of sleep medicine and developmental neuropsychology for more than 15 years, and also published her research in high-impact peer-reviewed journals, and has authored 4 widely used books on sleep and pediatric sleep problems. Also, she has been invited to present her research at international conferences all over the world, and her research has been featured in many international publications and also on TV, radio programs and governmental discussions. Additionally, I want to mention that she's a board member of the International Pediatric Sleep Association and several of its committees, and it's currently a member of the Scientific Program Committee of European Sleep Research Society and the Sleep Medicine Committee, Pediatric Sleep. Also teaches the World Sleep Academy, and her center is now on international sleep research training for the World Sleep Foundation. Also today we have with us Professor Oliviero Bruni, a full professor in child neurology and psychiatry in the Department of Development and Social Psychology at Sapienza University, Rome. And he's also a director of the Child Neuropsychiatry Unit of Sant'Andrea Hospital in Rome. Professor Bruni is a founder and past president of the International Pediatric Sleep Association, field editor of the journal Sleep Medicine, associate editor of the European Pediatric Neurology Journal, member of the Education Committee and the Examination Subcommittee of the European Sleep Research Society. He is currently part of the scientific committees of IPSA, World Sleep Society, European Sleep Research Society, and the International Restless Sleep Study Group. And also, he organized, acted as faculty member, and participated as invited lecturer in several international congresses. He has been involved in sleep research and clinical care in children for over 30 years and has published more than 250 peer-reviewed papers, in addition to books, several books, chapters, and abstracts he wrote. The third speaker of today's webinar will be Professor Dr. Silvia Miano, full professor of neurology at the biomedicine and a licensed psychotherapist. Her sleep experience involves central disorder of hypersomnolence, neurocognitive consequences of sleep disorders, and pediatric sleep disorders. Her research also focuses on treating sleep disorders in those affected by developmental neuropsychiatric disorders. She has been involved in sleep research and clinical care in children for over 20 years and has published more than 200 peer-reviewed papers in addition to several books, chapters, and abstracts. Also, today, Professor Lourdes Del Rosso will join the webinar. She is a sleep physician at the University of California. She earned her medical degree at the University of Miami, completed a residency in family medicine at Kaiser Permanente UC Irvine, a sleep medicine fellowship at Louisiana State University, and a master's in medical education at the University of Pennsylvania. Dr. Lourdes is dedicated entirely to the field of pediatric sleep medicine in area of education, clinical care, and research. She is involved nationally in the American Academy of Sleep Medicine and internationally in sleep medicine courses in Latin America. Her research focused on restless sleep and the consequences of sleep disorders. And Dr. Lourdes is originally from Peru and moved to the United States at the age of 18 years old. She lives with her husband and enjoy hiking. Just a short summary, as I mentioned before, the title of this webinar is Sleep-Related Phenotypes, Future Direction for Insomnia, ADHD, and Restless Sleep Disorders in Childhood. The link of the webinar event, you will find it on the event webpage, and also there you can find the register link if you want to register during this presentation and attend this webinar. Also, the recording of this presentation will be available after 1 week and will be posted on the webinar webpage. Now I want to invite Dr. Karen Sprut to start with the introduction.
So it will be a very brief introduction. So a warm welcome to each of you, and I thank you for attending this MDPI webinar on the topical collection Sleep in Children. So it's for this first webinar, I have invited eminent speakers on the topic of insomnia, as you already briefly saw. And so insomnia is defined as difficulties falling asleep, difficulties maintaining sleep, as well as early awakenings, and it's a very common complaint. So moreover, it is a persistent difficulty with initiation, duration, and the consolidation of sleep, and this despite adequate sleep opportunity and sleep settings. So it involves also perceived daytime impairments, such as an altered mood, sleepiness, cognitive difficulties, and also an increased health risks. So due to the challenge in diagnosing and assessing insomnia, the prevalence and incidence rates may vary widely, yet the rates remain overall high. And so about 10% of the general population suffers from chronic insomnia, or said differently, they struggle with sleeping for 3 months or longer. In childhood, prevalence rates are estimated to be range from 10 to 39%, and even higher prevalence rates in subgroups of children, such as those with chronic medical disorders, psychiatric issues, or neurodevelopmental disabilities. So that said, as an introduction, a very short introduction, the complaint of difficulty falling asleep, of difficulty maintaining sleep, or early awakening might be a symptom or a comorbidity. And recent data even suggest that these complaints might be transdiagnostic. And that is exactly why I chose these eminent speakers for you today. So I would like to extend a very warm welcome to the speakers because of their willingness to freely share this knowledge on, and I'll briefly highlight it. Dr. Professor Bruni will be describing phenotypes of insomnia and early childhood. And so his presentation will highlight the importance of the early identification of the phenotype as it might guide treatment approaches. Dr. Miano will demonstrate that sleep assessment in children with ADHD, that it confirms the validity of a sleep phenotype. And her research in children with ADHD reveals a much higher percentage of sleep problems than that reported in the literature. On the other hand, Professor Del Rosso will focus on the group of children in which restless sleep has been identified. And these children do not fit the criteria of any other current diagnostic category, and parents are concerned that nighttime restlessness is associated with excessive sleepiness, cognitive or behavioral problems. So before we begin with the webinar and the presentations, so the little household rules is keep the microphones mute when we are not talking, and have the question and answers will be at the end of the webinar, but please go ahead during the talks to put them in the chat box or the Q&A box. So due to a last-minute conflict in the agenda of Professor Del Rosso, she will start this webinar, and so the questions can follow her talk immediately. So to introduce Professor Del Rosso, which I met several years ago, and whilst working together with her, we became friends. She's a dear friend to me. And so she's now working as a sleep physician and a professor of family and community medicine at the University of California, San Francisco, Fresno in the United States. And so she's especially doing an impressive job in bringing sleep into the offices of every single healthcare professional around the globe as a director of the World Sleep Academy. So it is safe to say that Professor Del Rosso, that she put sleep on the world map. Another aspect on which she pioneered in this topic is actually her talk today, and that is restless sleep disorder. So Professor Del Rosso, the stage is all yours.
Thank you very much, Professor Spruit. I really appreciate it. It's an honor for me to be here and to talk to you about this disorder that has been collaboration of many of us and many countries as well. So thank you very much. And we're going to be talking about restless sleep disorder today. And I'm going to be summarizing at the beginning what we know so far about restless sleep disorder. And I want to tell you as a little bit of an introduction, as a sleep physician many, many years ago, we saw a group of children and parents that would complain about restless sleep and moving a lot in bed when they were falling asleep or when they were asleep, falling out of bed, being restless all night and having daytime symptoms. And at the time, about 5 years to 10 years ago, or even longer, we could not characterize this into any disorder. So a group of us dedicated to study this disorder published several publications, initial work that marked the beginning of a new disorder. And when we published, many of our colleagues, pediatricians, were so on board confirming that in fact we all have been seeing at the same time in various parts of the world this condition, and we just waited to put the data together. So these are the first main publications about restless sleep disorder. You can see collaboration with Dr. Oliviero Bruni, Dr. Raffaele Ferri, and other colleagues from various parts of the world with various areas of expertise as well. This first publication served to characterize the physical characteristics, video polysomnographic characteristics, and the symptom presentation of children with restless sleep disorder. So initially, this was the very first pilot study. We compared the patients and the children that the parents were concerned about restless sleep and daytime symptoms. We compared them with controls and with children with restless leg syndrome. And what we found was that there was this in yellow were the differences. Children with restless sleep had restless sleep, large muscle movements, while children with restless legs did not, but had leg discomfort and awakenings, and as expected. Also, children with restless leg syndrome had family history. The other symptoms in terms of daytime symptoms were actually similar between restless leg syndrome and restless sleep disorder, and different from children with controls without a sleep disorder. We did polysomnographic studies on these children. We actually studied the videos and we looked at the movements and we counted the movements. We realized that children also were affected when compared with controls, were affected in total sleep time and in number of awakenings per hour. You can see that children with restless sleep disorder slept less and had more sleep disturbance. However, they did not have, particularly in this age group, symptoms of insomnia, and their sleep efficiency would have been read otherwise okay. So for many years, one of the trouble that we had is that we did sleep studies in these children, and based on our current guidelines, we could not identify any specific disorder. When we looked at movements in particular, if we only looked at leg movements, they wouldn't be different than controls, although they would be different than children with restless leg syndrome because they expect to move more the legs, either have more periodic leg movements or isolated leg movements. What they did is they had large muscle movements that were different. So they moved more, they repositioned more, they changed movements through the night. So what the parents were saying was correct. The parents were complaining that any time that the parent would enter their bedroom, they would find the child in a different position. So what we found in this study was that it doesn't matter at what hour at night. So it could be at 1 in the morning, at 2 in the morning, the children were moving and repositioning similarly at a rate of about 5 movements per hour. And we found out that 5 movements per hour had a high sensitivity and specificity to discriminate from children with restless leg syndrome and from normal controls. The low numbers here at 9 o'clock and at 6 o'clock is because there's less patients falling asleep at that time. But children were consistently moving through the night, regardless of the time of the night. They were indeed found in a different position. Making a parenthesis at this level, I just want to mention that there are studies that have confirmed that parents are quite accurate in describing sleep complaints with their children. So they are trustworthy and they are our really good partners in diagnosis and treatment because they are the ones at home observing these behaviors or movements. So the summary of these 3 first studies was that there was sleep disruption in children with restless sleep without significant difficulty falling asleep. So the children weren't presenting with insomnia symptoms. There weren't symptoms of discomfort or leg movements in particular, but they were large body movements at a rate of more than 5 per hour. So this initial important work brought up a large task force, but says, and this was a large task force that we looked at. I was an international from pediatric sleep doctors. Some of us are here in the webinar from all over the world. And we met together over a couple of years and we studied the literature. We reviewed what the literature said about restless sleep disorder. And we published a diagnostic criteria for restless sleep disorder, which includes the parental complaint of restless sleep, which includes the need to have large muscle movements at about 5 or more per hour, and also must include a degree of chronicity, because we found out that some temporary disorders like pain or eczema or uncontrolled asthma can also present with restless sleep. So it has to have at least 3 times per week. It must be present for at least 3 months. Importantly, it has to have daytime impairment associated with a poor sleep quality. So some behavior, some problems in school, some degree of functioning has to be affected either by parental complaint or by objective findings. And it must not be explained by another sleep disorder or medical condition, as I mentioned, eczema, seizure disorder. Even though we are slowly finding out that there can be an overlap, the whole symptomatology cannot be fully explained by the medical or sleep disorder. For example, if a child has obstructive apnea, but is adequately treated with CPAP and continues moving, then if the restlessness is not adequately explained by the initial diagnosis, then consider secondary diagnosis of restless sleep disorder. Some supportive data is that the movements occur throughout the night, and as I mentioned, sleep onset delay is uncommon. It's important to recognize some of the terminology and some of the mimics and differential diagnosis for restless sleep disorder. As I mentioned, the parents will be concerned that the child trashes the bed, they move like a helicopter. These are terms that they have used with me. Very restless, never stops moving. Some mimics will be dermatitis if the child has eczema, if the child has pain, migraines, uncontrolled asthma. Some types of insomnia, like Dr. Bruni is going to talk later on about types of insomnia with restlessness, some other disorders. Some rare mimics include seizures. I'm giving you the heads up that work is being done on children with seizures to assess comorbid restless sleep disorder, and also some sleep starts and tics. Now I put weather because there were a couple of publications in which really heat or very cold can also produce restless sleep in some people. And this is again a summary of the common mimics, including some sleep disorders, medical disorders, and the less mimics, which are sleep-related seizures, motor tics, or other sleep disorders. Did a prevalence in our sleep center, which is a large sleep center. When I was at Seattle Children's, we had a 12-bed sleep lab, and we saw at least 6,000 patients a year. So we calculated the prevalence in our referred population to be 7.7%. So it's a little bit less than restless leg syndrome, very similar prevalence to insomnia. Now, this is not in the general population. This is in children that are referred with sleep complaints to a sleep center. As you can see, and as you can expect, the majority of the referrals continues to be snoring and obstructive apnea, but we do have other disorders, especially parasomnias, restless leg syndrome, insomnia, that are referred for sleep evaluation. So since then, it's been 3 years since those initial papers or more. I think we started working in 2017 on this diagnosis. And since then, a lot has happened and many more papers have been published. So I'm going to talk a little bit about some of these objective measures that we are finding out, some papers, publications that are identifying comorbidities associated with restless sleep disorder, and some actually objective ways to identify daytime symptoms. So first of all, we needed an objective way to assess these large muscle movements. And this is an image for those of you who are familiarized with polysomnography. You could very easily identify this image is an epoch, is a 2-minute epoch. For those of you who are not familiarized with polysomnography, the top leads, this is a screenshot of a polysomnographic finding in which the top leads are a limited referential EEG that has 2 frontal leads, 2 central leads, and occipital leads, which are used for sleep staging. We have eye leads to see the eye movements. We have a muscle tone leads, which is electromyogram, which are attached to the chin and to the legs to assess movements. We have a snoring microphone, a single lead EKG, and our respiratory flow measures and our bells for chest and abdomen to see effort. Also, we have an oximeter, a heart rate, and a capnography, which measures end-tidal CO2 and transcutaneous CO2. This is stage N2 of sleep, and we can see that the child in this case is sleeping in N2, has a large muscle movement, and continues in N2, so that's not wake up. So we had to develop a scoring system to be able to assess, quantify, and score these movements uniformly all across sleep centers in the world, to be able to speak the same language when we diagnose or where we publish research, if any of you is interested. So it is there. We have already published these guidelines for scoring. In the very first paper, we use video scoring, but currently we are validating the guidelines without video, when we can see the very first increase in muscle tone with a movement artifact, and the last decrease in the tone, and we calculate the length and the presence. So this is just very briefly to let you know there are published scoring rules, that we use the tibialis muscles or the chin, and we can also use any of the leads that can present the movement artifact, like the EEG leads or the eye leads or even the EKG. We can have a body position, and some labs can use all the other EMG channels, but these are optionals. Like when some labs can do parasomnia montage with, or REM behavior disorder montage, and use other sensors. I need to mention that one of our colleague sleep centers in Cincinnati did scoring of large muscle movements using arm leads as well, and they found no difference, no extra benefit from adding arm leads to our restless sleep disorder children. Just as an example of when to start, when you see the increase in the artifact, when to end, and there are some guidelines as of when to call one movement or two movements that I'm not going to go into detail. Here is the manuscript led by Dr. Rafael Ferri and the team of experts in this movement assessment. Since then, we've also been studies the presence of comorbid restless sleep disorder with other common conditions. And when we presented this diagnosis in various meetings, the very first question that we had was, what about ADHD? What about patients with attention deficit hyperactivity? Because these patients have a really high hyperactivity, and it's a 24-hour disorder. So it was very intuitive to think that they would also move a lot at night. And indeed, we found an increased presence of a restless sleep disorder, 9%, still less than restless leg syndrome, still less than depression, but something to take into consideration. A little bit higher than insomnia. Remember, it was 7.7 in our referred population, but it was very similar to insomnia. In this case, it's a little bit more increase to 9% prevalence of restless sleep in ADHD. So important to assess in your patients with ADHD whether they have restless sleep and whether they're moving a lot at night. Our colleagues in Turkey had a very interesting publication on restless sleep disorder in children with non-REM parasomnias. And what they found was that the RSD was present, can be a comorbid condition, and when it's present, sleep quality is worse. So it is very important to know that if there is restless sleep disorder, maybe children with parasomnias will have worsened sleep quality, increased arousals. So patients maybe with persistent parasomnias or multiple awakenings at night will maybe screen also for restless sleep disorder in this patient population. So very interesting publication. The same group started to look at large muscle movements in patients with epilepsy, with seizure disorder. So we can see here that we have a patient with a epilepsy compared with parasomnia and compared with no diagnosis, but paroxysmal events at night. And you can see the presence of RSD was higher in the epilepsy group. And you can see also the large muscle movement index in each group, whether or not it was higher than 5 or lower than 5. So you can see that we are starting identifying some groups of people, and especially children, that could be at higher risk of more restless sleep or combine restless sleep disorder with another medical or psychiatric condition, neurodevelopmental disorder, etc. So it is very important to assess sleep quality in these patients and assess for a sleep disorder, not only obstructive sleep apnea, which we're used to assess in patients with ADHD and epilepsy. One of the concerns that we have is that if they have obstructive apnea, it worsens their symptoms or it lowers the threshold. But now take a look into sleep quality, restless sleep disorder, restless leg syndrome as a potential contributor to the symptoms. How do we treat restless sleep disorder? Well, very, very early in our research, we found out that children had low ferritin levels. Children with restless sleep disorder had very low ferritin levels, and iron supplementation improved symptoms. So in this section, we're going to talk a little bit about how iron improves symptoms, what could be these iron deficiency mechanisms, and also what can we do in these patients in terms of other sleep movement disorders or complaints. So our very first publication identified children with RSD as having ferritin levels of 20, which was significantly lower than even children with restless leg syndrome, which is 30. Something that is important to remember is that the normal range of ferritin in children can be 15 to 100, and in adults is even higher. It can be up to 400. But something important to know is that there is a condition called non-anemic iron deficiency, in which iron could be deficient in parts of the brain and in other parts of the body, and ferritin less than 50, less than 30 have been significantly associated. There is not a consensus of when this non-anemic iron deficiency is. Most papers point at a ferritin of 30, but you know, for restless leg syndrome, we target a ferritin of 50 to treat these children. We also look at other iron parameters because ferritin is an acute phase reactant, so it can be increased in other medical conditions. So we want to know that indeed saturation is also low, TIBC would be high, and iron levels are not exceeding high. I usually recommend to get this test done fasting because iron is very vulnerable to dietary intake, and fasting would be a better, more reliable test. This is our comparison treatment of oral iron and intravenous iron, and I'll just guide you through this busy slide. This is the age of our patients and the range of the age. This is a clinical global impression severity scale. 5 is quite severe, and ferritin levels range from 13 to 23 and 13 to 20 in IV iron. So we usually start with oral iron, but in children that do not tolerate, have contraindications, have significant side effects of constipation, abdominal pain or discomfort, or do not respond to oral iron after 3 to 6 months, the ferritins remain low, we offer intravenous iron. And so we'll talk a little bit more about that. And in this publication, we compare the oral iron versus the intravenous iron. And you can see all the other parameters in the sleep polysomnography were not different, including the apnea index or the period or the leg movements for this population. And we can see how you can see the comparison of after oral iron after 3 to 4 months. You can see the initial was 16 in both groups, and after oral iron, it improved to 34, which is not bad. You can continue for 3 to 4 more months, and it'll pretty much reach 40 or 50, which what you want. So the message is that with oral iron, you need a longer treatment, while with intravenous iron, after 8 weeks, it improves, ferritin improves to 124, and symptoms improve significantly. You can see the clinical global impression goes to a range of 1, which is pretty much resolved, to 2, significantly improved, while in oral iron only went to 3, which is some improvement or moderate improvement. It is very important to know that there are some children that will not respond. So it is important to check ferritin levels at 3 months. Again, with intravenous iron, significant faster improvement, but also some side effects and some concerns because it's an IV iron, can have allergies, can have other side effects, rashes, fevers, among other concerns, but more benign, but slower is oral iron. The preparation that we used for this study was ferric carboxymaltose. So some very briefly, iron deficiency, whether anemic or not anemic, and some of the data that we have about how iron deficiency affects movement and the brain development. So it is important to know that when iron starts being deficient in the body, the blood cells and hemoglobin prioritizes iron to prevent anemia. So the changes in iron indices, such as hemoglobin, are a very, very late marker of iron deficiency. Also, iron deficiency can, early iron deficiency can disrupt development in key areas of the brain. And some of those areas appear to be early myelination and hippocampal development. So here we have a time base from birth to 1 year. And yesterday I was actually talking to our fellows about a 3-month-old with iron deficiency, 6-month-old, premature infants. Very important to identify this because this is an area of large neuronal formation, brain development, myelination. And we know that, for example, movement is not fully developed when a child is born or even at 6 months. We have continuous development. That's what infants cannot sit. They do not have that pyramidal tracts developed or the myelinated as well as later on. So they don't have that fine motor coordination. they don't have muscle tone. So all of these tracts are myelinating later on after birth, and iron is important for this process of myelination. This is a study early on in which infants with anemia, which is the white boxes, were compared with infants without anemia, and this was at 6 months. And you're looking at the activity and the motor activity during sleep, asleep during the day and asleep during the night. And you can see how motor activity was higher significantly and statistically significant in children that were anemic. So they were more restless, both during quiet sleep and active sleep. What is interesting is that these children had the anemia corrected, so they were no longer anemic, and there were studies done later on when they were 10, 12 years old, and you can identify some of the names here in Patricio Peirano and Dr. Rafael Ferri. You can identify some of these names, and you can see that in the former iron anemic group, there were still increased movement in the legs as a periodic leg movements compared to the controls. And these were no longer iron deficient children. If you talk to neonatologists that work with premature or iron deficient children, they will tell you that there are some things that completely resolve after iron deficient is controlled and some that don't. So we can see that maybe some of these movements or these PLMs are not fully restored. In terms of cognition, we have pathways that are involved in development of neurocognitive functions. Dr. Karen Spruitt is a neuropsychologist. She is an expert in this area, but she can verify that there are pathways in the brain that are dependent on neurotransmitters that need some substances like iron to be produced in the brain. Attention is one of those, and attention develops over the years. By the age of 7 to 10, selective attention depending on the frontostriatal dopaminergic pathway, and we need iron to form dopamine. So important to identify iron deficiency for children, especially with attention problems. So the consequence of iron deficiency can cause some myelination problems that are associated with brainstem responses, but also at the level of cognition, inattention, language skills, sleep pattern disruption, motor development, slow processing speed, and social interactions. So this is all I have for today. I am available for some questions, which we're going to do them early rather than later due to my time constraints. I do want to give you a little bit of heads up that we have published since then attention deficit in neurocognitive function in children with some subtle attention deficits in children with RSD, and that we are currently looking into RSD in adults. So those are some directions for the future, but I'm open to some questions that you may have.
Hi, Lourdes. Thank you very much for your really excellent presentation. So, as always, it's a pleasure to listen to your informative, really educative talks. So, I've tried to keep an eye on the question, and I think it's not a question; it's a comment. It's like a big thank you for your talk. So I do have one question, just one in terms of, I saw in terms of depression, and it just mentioned in one of your last slides in terms of dopamine. So specific or special populations, do you have any idea on prevalence or higher prevalence rates or co-occurrences in those children and those with special education, special needs children? Do you have any feedback or comment on that?
Yes, so we actually had a study on in children with autism spectrum, and as you know, there's a lot of challenges in children with autism depending on the severity, but one of them, the biggest challenge I feel, is the sensory processing. So it is very difficult to assess restless leg syndrome in children with autism. And therefore, whether they're moving, whether they're kicking, and on top of that, it is very difficult to have a sleep study. So polysomnography in children with autism is difficult due to the sensory, the communication, a lot of the above. So we did a study, and we published the study in which we had high suspicion of restless leg syndrome, and they did not fulfill all the criteria, but we had a low threshold to check iron levels in these children. And we supplement iron and sleep in those that we were almost 100% sure that they had restless leg syndrome because of some physical movement and rubbing legs or something. Those 100% improved after iron. But on the ones that we had suspicion, but it was not confirmed, 80% improved after iron supplementation. So for those children that have significant neurodevelopmental delay, that are nonverbal, that have sensory processing disorder, that you can't do a sleep study to assess for these movements, I would recommend to check iron levels, and if they are less than 50, to supplement, because it is just going to be overall beneficial not to have iron deficiency at this stage.
Okay, thank you. And then to know the future, is there or are there sleep questionnaires that really stagger or really target this? Are they in the pipeline, developed, or?
We are in the, it is in the pipeline questionnaire that we want to start working on and validating. So hopefully we'll all work together on that, but we have some early ideas.
Okay. Okay, so thank you very much for doing this, and I'll let you go because I know you have your agenda is full for today. So
I think Dr. Miano had a question.
Oh, awesome. I didn't see. Yeah, go ahead.
Yes, thank you, Professor Del Rosso. You always present very nice data about it. And I was curious if you think that reintroducing movement time as a criteria of scoring of pediatric sleep polysomnography may help to diagnose and recognize restless sleep disorder.
That is a very interesting concept, and in all honesty, we haven't thought about it. We have seen in our review of the literature that some publications in the past use movement time, but we stayed with the index. So because a lot of things are moving towards index and towards automation, we stayed with it. But I think it is a very interesting idea, and if we should pursue, or you want to lead and pursue, I think and if you want to explain maybe to our audience what movement time, instead of expressing an index, you express it as a time spent in movement, right? I mean, you may want to say a little bit more about it.
Yes, it is a percentage, if I remember well, according to Rechaffen-Keil scoring. It's a kind of epoch in which you cannot recognize sleep because it's covered by an artifact, and usually in children is covered by an artifact because of gross movement. So it can be another marker for this kind of disorder.
Absolutely.
And it's a pity that is disappeared from the scoring of sleep.
Yes, I agree. And I'm really thankful that you brought this up, because during our literature research, we found that early on, movement, restless sleep was also part of the manual, and movements, and a lot of this was part of the manual, and eventually it started disappearing. And I think that it would be very important, because if we only look at a movement, that movement could last 40 seconds, while another movement can last 4 seconds, but in our current scoring, it will only be characterized as one movement. While if we do movement time, it may give us an extra guide and an extra
extra information.
Exactly, exactly. Thank you so much for bringing it up.
So as you can see, questions raise more questions. So thank you, Lourdes, thank you, Professor Del Rosso. And so I'm also happy that apart from as a special population or special needs children, that you brought up autism, because Dr. Silvia Miano will discuss on ADHD, which you also mentioned. So we'll go on with the second talk. And so I have the honor to present to you Professor Miano, who is also a dear friend for many years now. And so we share a sleep research interest, which is sleep in children with special needs, special populations. So Professor Miano is also a sleep physician and is the head of the sleep unit in the Civic Hospital of Lugano and Neurocenter of Southern Switzerland. So as a professor of neurology, she has always had an innovative look at developmental neuropsychiatry. And I would like to invite you all to keep an eye on her research work. And so today, she agreed to bring her insights on the sleep phenotypes in ADHD, a distinction between the primary and the secondary forms. And so thank you, Sylvia. And so the stage is yours.
Thank you, Karen. I'm very happy that you invite me and giving me the opportunity to summarize all the studies that we made on this topic over, I think, 15 years. So thank you very much. And here you see the outline of my presentation. I will start with the introduction of this topic and some literature data supporting the idea of sleep phenotypes in ADHD. And then I will show you some data about sleep microstructure and slow wave activity studies on ADHD. And then my personal studies on sleep phenotypes, topographic mapping of slow wave activity, and sleep microstructure in terms of cyclic alternating pattern analysis, and finally, my conclusions. And some years ago, maybe 15 years ago, to address the complexity and heterogeneity of sleep disorder in children with ADHD, I proposed 5 phenotypes. One, sleep onset insomnia, that can be considered a marker of a later development of delayed sleep phase syndrome in these kids. Another, the sleep model related phenotype associated to restless syndrome or periodic limb movements. Another very common comorbidity in ADHD, obstructive sleep apnea. And finally, an hyperarousal state resembling narcolepsy, which might be considered a primary form of ADHD, considering that treatment is quite the same with stimulants. And finally, an epileptic phenotype, which is always undercovered. And here you see a detail of such hypothesis, and you can suppose an alteration of circadian process in this phenotype of sleep onset insomnia with a consequent sleep loss and sleep death, an alteration of process S of the homeostatic process in all sleep disorder inducing sleep fragmentation, such as OSA or epilepsy sometimes. And finally, an alteration of ultradian process in the primary form in the narcoleptic-like phenotype. And moving to literature data, there are many subjective and objective studies showing that about 1/3 of children with ADHD may suffer of chronic sleep onset insomnia. And especially in adolescents, the sleep onset insomnia is a marker of an evening chronotype, and there are some evidence of a delayed secretion of melatonin in these children. And it has been also underline an association between sleep onset insomnia and internet addiction and addiction to video games, which is very common in teens with ADHD, and there are a higher percentage of children with ADHD with an addiction for more than 6 hours per day, inducing excessive daytime sleepiness. And it has been hypothesized that this is not the reason why they have a sleep onset insomnia, but it can be the possibility that the relationship may occur the other way around, that increased technology use occurs after sleep becomes more problematic in these children. And here, this is a support of this hypothesis. This is an elegant study from the group of Paul Greengrass in London. It is the Avon longitudinal studies assessing sleep by questionnaire in a very large cohort of children, and over time, about 2% of them were diagnosed for ADHD. And if you look at the total time of sleep from birth, from the first months of life until school age, you can see that always the children with ADHD slept less for about 10 minutes over over years, and this can be a significant sleep loss. And the main reason was always a later bedtimes. And now moving to the other sleep phenotypes hypothesized, as it has been already well described and explained by Professor De Rosso, iron deficiency starting from infancy may induce increased numbers of periodic or non-periodic limb movements during sleep in childhood, and with an increased risk to develop ADHD. And it has been a genetic endophenotype related to iron deficiency, ADHD, and restless syndrome. And in my opinion, the category of restless sleep disorder is more significantly associated to ADHD. And then I will explain you later on the reason why. And also a support that an increased movement during the night and sleep movement during the night is associated to ADHD is by this important study, again, a longitudinal studies assessing persistence of insomnia in a large sample of children from 4 years of age to 18 years of age, and the authors found a persistence in about 9–10% of cases. And in those with complaining of sleep movements, there is an association again with ADHD. And moving to the last, to the third kind of sleep phenotypes, obstructive sleep apnea, there are huge literature data evidencing and demonstrating that early respiratory problems during sleep may result in possible neural injury in the hippocampus and prefrontal cortex, the same regions that are implicated also in early iron deficiency. And HOSA is associated to intermittent hypoxia during the night and also increase in sleep fragmentation, and both inducing a cascade of pro-inflammatory marker, inducing a final alteration of microvessels in the brain barrier that can be the reason why you can find such alteration in the brain, as it has been demonstrated by MRI, volumetric MRI, by many groups. In children with apnea index more than 5, you can find a decrease of gray matter volume over prefrontal cortex and also hippocampus. And for this reason, now for about 10 years, since 10 years, the Pediatric American Guidelines recommend that children undergoing the evaluation for ADHD, before starting treatment with stimulants, they should undergo an assessment for OSA. And this is a very old paper by when I was working in Rome, in which we found that children with OSA has a slight deficit of global cognitive score, and the cognitive ability are positively correlated with the percentage of wakefulness during sleep, and also positive correlated with arousal, and also with the other marker of arousal in terms of cup rate. And also we found an increase of cup rate in these children, and a negative correlation between arousal, wakefulness, and hyperactivity. And the meaning of that is that in these children, arousal is a defensive mechanism preserving cognitive function by counteracting the respiratory events at the expense of sleep maintenance and non-REM sleep instability, as expressed by the increase of CAP rate, and at the expense of executive function and ADHD. And there is an important meta-analysis published about 10 years ago supporting and confirming that treating OSA can also be a valid treatment for ADHD. And here you have two examples. One in the same journal, the Journal Attention Disorder, describing a boy, an adolescent, that was misdiagnosed as ADHD and also complaining of daytime somnolence, who finally undergo a polysomnographic recording disclosing OSA. And he started therapy with CPAP with a complete disappearing of inattentive symptoms. And here you see another example from my group when I was in Rome, in which you can see the same pattern. It was again an obese Caucasian adolescent, a syndromic with very severe migrainaxia, who referred snoring and apnea from birth, and that was diagnosed as ADHD and treated with methylphenidate and fluoxetine 4 years. And here you can see the severity of the OSA with an apnea-hypopnea index of about 100. That is impressive. And the starting treatment with CPAP induced an amelioration and disappearing of OSA, but it was too late for the cognitive ability of this boy, who was in a sort of a neurodegeneration and dementia due to the chronic intermittent hypoxia. And moving to the other phenotype hypothesized, the narcoleptic-like phenotype, there are some data demonstrating by multiple sleep latency tests that children with ADHD are about 8 times more likely to fall asleep. And also there is a specific endophenotypes, a neuropsychological characteristic of children that is called slow cognitive tempo, the specific features during the daytime. Boy and girl can be lethargic, slowed, forgetful, and having a daydreaming behavior that is associated to excessive daytime sleepiness. And also in the other way around, it has been found in about 30% of children with narcolepsy, the comorbidity with ADHD. And the last phenotype, the epileptic one, at this moment, as I have already told you, the number of studies available for such relationship are still scarce. But I want to remind you that ADHD is more than 2 times higher in children with epilepsy, and sometimes precedes epilepsy. And in children with epilepsy, there is in about 25% of cases, if you do a prolonged recording with multiple EEG channels, the occurrence of epileptiform discharges. And if they are abundant, they can worsen the prognosis of ADHD. And here you see an example in our lab. This is a girl of 14 years old with a diagnosis of ADHD. And here you can see the clear epileptiform discharges during sleep, and they were so abundant that she started treatment with anti-epileptic, inducing amelioration of symptoms, but she still persists complaining of insomnia. So she repeats a new polysomnographic recording with disclosing and demonstrating a mild obstructive sleep apnea, so she underwent also adenotonsillectomy. This is an example to see how frequent can be a comorbidity with not only one, but sometimes also more than one sleep phenotype. Now some data about sleep microstructure and slow wave activity in this population. Here, just to remind what is CAP. CAP is an oscillating pattern exhibiting different levels of arousal during non-REM sleep, and it is composed of EEG transient, the phase A of CAP, with different level of synchrony, synchrony activity at the EEG, which is mostly composed by slow wave activity, and it is called A1 subtypes, and you have more component of desynchronized component and fast activity in A3 and A2 subtypes of phase A. And phase A is alternate with phase B, which is a return to background activity, and then you have this cycle, and at the end you have the sum, that is the CAP rate, which is a measure of non-REM instability. And as you can see here, CAP rate progressively increase over time during pediatric age, resembling the development of slow wave activity and mirroring the synaptic downscaling in adolescence, in which you have a peak of CAP rate and then an abrupt fall of CAP rate reaching the adults level. And as you can see here, this is a topographic mapping studies of CAP in collaboration with Dr. Ferri, and you can see that A1 mapping over prefrontal and anterior midline cortex, while A2 and A3 subtypes, more similar to the classical concept of arousal over posterior and parietal areas. And in children with ADHD, without epileptic discharges and without a clear comorbidity with sleep disorders, as demonstrated also by a meta-analysis, you can find a lower CAP rate compared to controls, and especially a lower A1 index during stage N2, which seems to be specific of an executive dysfunction in children. And a similar pattern of CAP rate has been also described in children with Rolandic epilepsy, pediatric narcolepsy, and learning disabilities. Whereas in children with pediatric causas or encephalopathic epilepsy, it has been described an increase of CAP rate, not a decrease of CAP rate. And looking to the slow wave activity, as you know, the sleep-related slow wave activity has been recognized having a crucial role in neuroplasticity, either in short-term synaptic downscaling during the first part of the sleep, and also for long-term plastic changes over developmental age, as it has been demonstrated by this elegant study from the group of Reto Huber in Switzerland, in Zurich, in which you can see that the slow wave activity map changes over time from the first years of life over posterior area, spreading over central and then anterior area over school age and adolescence, reaching the level of adults in young adults. You can see the slow wave activity over prefrontal cortex. And this is a mirror of the cortical development. And in ADHD, it has been found that these slow wave activity are not correlated with the typical declarative memory consolidation, as you can find in controls. And also it has been found a delay of maturation of mapping of slow wave activity by high density EEG analysis by the same group of Reto Huber, with a mapping of slow wave activity over more central area than in controls in the same age of about 12. And this was an analysis in the first part of the night, in the first cycle of the night. So summarizing all of this data, you can wondering why an increase of arousability and a decrease of arousability may induce an executive dysfunction in children with ADHD, looking at the comorbidity with sleep disorders. And as you can see in this review, normally the arousal implicate an activation of many ascending monoamine system, inducing activation of prefrontal cortex, and this is in the normality. But if you have a chronic stress, you have a switch on more primitive brain and a decrease of prefrontal activity. And also during sleep, during the first part of sleep, you have a switch off of prefrontal activity and all the stimulants neurotransmitter of wakefulness. And both the sleeping or a reduction of vigilance that you can have in a state of hyperarousal or an excessive increase of arousal may induce a decrease of prefrontal activity. And if you look, it's not working, sorry. Okay, if you look at sleep, you can hypothesize that prefrontal dysfunction can be caused by an increase of arousability that you can expect to find in sleep disorder briefing, sleep onset insomnia, periodically movements and epilepsy in children with ADHD, or a decrease of arousability in the primary form or in Rolandic epilepsy. And that was my hypothesis. Now, moving finally to the findings of my studies, I present the results of a prospective case control sleep studies in children with attention deficit hyperactivity disorder, aimed to identify all this sleep phenotype by a full sleep assessment. And also they were recorded by a full high density EEG, and also we perform a CAP analysis. And here you see the last paper about. And the particularity of this these studies is that children were recruited at the pediatric unit, not for sleep disorder. And they represent a real sample life, not with a clear comorbidity, not complaining of sleep disorder. And they were assessed by video polysomnographic high density EEG recording, a multiple sleep latency test, and 1 week actigraphic recording, and several questionnaires. And here you see the results. And we found a narcolepsy-like phenotype according to the MSLT findings in 4 children, a sleep onset insomnia according to actigraphic recording in 5 children, OSA in 50 children, in about half of the sample, and periodically movements in 8 children above 5 without any symptoms of restless syndrome, and epileptic discharges in about 10 subjects, and 2 have parasomnias and only 1 no sleep disorder. All subjects had a total sleep time shorter than 9 hours at actigraphic recording and reported past history of sleep problems, and have a ferritin levels lower than 60. And looking to the polysomnographic recording, again, you see a decrease of total sleep time, a significant decrease of total sleep times, and a slight increase in all the sample of apnea-hypopnea index. And children belonging to the group with sleep onset insomnia were older as expected, and while children with narcolepsy-like phenotype had a neuropsychological test as a feature similar to slow cognitive tempo. And here you see a meta-analysis and a study with a collaboration with Dr. Fulda, which is an expert of restless syndrome, and it is part of the international group for studying restless syndrome. And in all the sample, in the same sample of children, we reanalyze periodically movements according to the last criteria of the World Association of Sleep Medicine, and we did not find any differences with controls, and also the meta-analysis of only studies in children with a DSD, not coming to the sleep lab, but coming to a pediatric unit and not complaining of sleep disorders, in which we found no differences of PLM. So if you have, the message is that if you have periodically movements in children with a DSD, you should suspect a restless syndrome. And in my sample, I didn't find any children with restless syndrome. And here you see the mapping, the results of the slow wave activity spectral analysis, and as it has been already reported by the group of Reto Huber, we found again an increase of slow wave activity over central and more posterior area compared to controls, and also not only the early sleep, but also in late sleep, which is a new findings, and also if you subtracted the delta power values from early sleep, you find a persisting of delta power over central region in ADHD, demonstrating an alteration of sleep homeostasis in these children. And also the origin of slow wave activity was greater over the posterior cingulate, mainly involving the right side in the ADHD group, and posterior cingulate is in relation to the default mode network. So it is well known that the default mode network was usually anticorrelated with prefrontal activity during wakefulness, and in children with ADHD is correlated. So this is an indirect confirmation of such characteristic of ADHD, a sort of dissociative state. And here you see the gap results in not all the sample, because we reanalyzed sleep after some years after the beginning of the study. And here you see the results of cap rate in all the sample of children, with again no significant differences between ADHD children and controls, and no differences in A1 percentage and A1 index, and also the distribution of A phases during stage N2 and stage N3 was similar. But if you look at the second step analysis, subdividing children according to the sleep phenotype, we found the differences. The group 1 was composed by children with the DSD and obstructive sleep apnea. Group 2 was composed by children with interictal epileptic discharges during sleep and DSD. And finally, the group 3 was composed of all the remaining children. And if you see, even not reaching statistical differences, we found a slight increase of cap rate in group 1 and group 2, a decrease of cap rate in group 3, and an increase of cap rate, especially during stage N3 in children with OSA, and a decrease again of A1 index during stage N2 in group 3. And this can be a confirm that by the sleep microstructure analysis, you can identify the secondary and the primary form of ADHD. That can be helpful also for treatment. In conclusion, a full sleep assessment in children with ADHD confirmed the validity of the sleep phenotypes hypothesis and revealed a percentage much higher of sleep problems in these children. All children reported a past history of sleep problems and have a chronic sleep deprivation. And chronic sleep deprivation can be considered a possible unified marker of ADHD that can compromise the physiological mechanism underlying cortical development in early stage of life. And looking at the cap rate, in the final summary, an increase of arousability and a secondary form can be hypothesized and should be confirmed by other studies by higher level of arousal in sleep disorder briefing and epileptic discharges phenotype of ADHD, while a decrease of arousability can be found in narcoleptic, sleep hyperkinetic, and sleep onset insomnia phenotype of ADHD. And this can be a guide also for treatment. And this is my last slide. I want to thank also my dream team in Lugano. Thank you.
Thank you very much, Dr. Miano. I enjoyed it. That's a wonderful presentation. And as a neuropsychologist, you know, I love it that you think of the umbrella of ADHD, really put that sleep phenotype. So thank you very much for this. So we'll continue then with the next talk, and for your questions, we'll do it at the end of Oliviero's talk. So I will now would like to introduce somebody that is very dear to me. It's the last speaker, but it's a very special speaker. Special importance to me. Dr. Bruni was at the crib of my research career, and so I immensely admire his lifetime efforts in the field of pediatric sleep. So he was the founder of the IPSA, the International Pediatric Sleep Association, and he presided this unique pediatric sleep association for 7 years. So I think we can say he is the pediatric sleep Wikipedia. So Professor Bruni is a professor of child neurology and psychiatry at the Department of Developmental and Social Psychology at the Sapienza University in Rome, Italy. And so his talk will be about phenotypes of insomnia in early childhood, the early identification and treatment. And if I understand well, it will be a very good end talk, giving the previous talks that we had. So Professor Bruni, we are all ears.
Thanks, Karen, for your presentation. So what I would like to emphasize with my presentation is that we are going more and more over a personalized medicine. So the more important point, as we can see from the presentation of Professor Miano, is that if we could be able to identify a specific phenotype, then we could improve our the treatment and we could improve the quality of life of our patients. So I will speak about insomnia. Just let me introduce what we include with insomnia. Insomnia is as you mentioned at the beginning, is a difficulty initiating and maintaining sleep, or early morning awakening, or resistance to go to bed for at least 3 times a week and for at least 3 months. But previously in the international classification number 2, the pediatric insomnia was divided from the adult ones, and with the 3rd edition, they include under the term of chronic insomnia. Still, there is a specific part in the classification that rely on the behavioral insomnia that is divided into 3 subtypes. That is sleep onset association type, limit setting, and combined type. So since there are 3 months is the definition of chronic insomnia, at 6 months we could also have a diagnosis of chronic insomnia. And we will see that the prevalence ranges from 15 to 30%, or even 40% in specific age group. But we could rely on the fact that between 10 and 30% during the developmental age is the prevalence of insomnia. And mostly the parents brings the child, and because they are sleep deprived, the parents are sleep deprived, and there could be several problems for the family stress and for the family functioning. But apart from the consequences, we could see that if we consider behavioral insomnia, we could have two kind of infants. The infant that with positive sleep association, that is like this one, that has no problem in falling asleep. She falls asleep alone without any eyes from the parents and without any parental presence. So no problem for this. But we have also the other face of the coin, that is what has been called the signalers, because as soon as they wake up in the night, they cry and wants to be calmed from the parents. So these babies that are crying at night, the only difference between the two groups is that this one need the parental presence or other issue in order to fall asleep. In example, this child only fall asleep with the water, so that we know that there are different kind of a way in which the parents let the child fall asleep. So this one, only one of the different treatment, or the different way in which the child is let fall asleep. But beside these two type of behavioral insomnia, we could think that what is an early sleep problem is probably predictive of a mental health problem. So we could always think about that what we are treating in the early ages might be a precursor and predictor of a mental health problem later on. Because if you see, in this period that is extremely important, and this we could say that is the insomnia peak period, the cortex that is developing is the prefrontal cortex. So the insomnia may directly affect the development of prefrontal cortex that are related to higher cognitive functioning and also to the mental health. So higher sleep problems predict poorer mental health in adolescents, affect control for early mental health and concurrent sleep-wake problems. This is extremely important because if we have a child with a very important sleep problem, we could improve the development of mental health in these children and avoid consequences on mental health. So it is extremely important to consider the treatment, the early treatment of insomnia. But you know, insomnia changes with ages. Differently from the adults, the insomnia changes with age. You see that in the first years of life, about 40% of infants wake up overnight, but and then decrease, especially at 3, 4 years or 5 years old, the prevalence of night wakings is decreasing. What is increasing only is the trouble getting asleep. That is a typical insomnia of school-age children. So in infancy and preschool, we have behavioral insomnia, colicky infants, or food allergy insomnia. In school age, we have a sleep onset insomnia with difficulty getting to sleep, and with nighttime fears. And in adolescence, we have inadequate sleep hygiene and stimulant and environmental sleep disorders, mainly in these last years related to the intrusion of technology into sleep of adolescents. So what the parents can do, commonly the parents buy some books or go through internet in order to find some way, some correct way to let the child fall asleep. But the main problem is, as you can see, that 70% of mothers with colicky infant had aggressive thought or fantasies towards their child, and 26% admit to thoughts of infanticide during calling episode. So it is extremely important because some cases of infanticide are related to sleep deprivation of the mothers. And what we should suggest? We suggest to avoid some practices at bedtime. So let the child fall asleep in the parent's arm, in the stroller, allow to touch hair or other parts of the body of the mother in order to fall asleep, give pacifier or herbal infuse or any other issue. But what happens in reality? In reality, happens this: we make the survey on the Italian practices at bedtime, and so to let the child fall asleep, the fathers put the child in the car and drive during the night in order to let the child fall asleep. They could play songs. Gas breathing is a practice that you can see in some movies of the Italian neurologist from Vittorio De Sica. There is an example of this, and put the child of the wash machine, punish the child, go to the pranotherapist, exorcist, osteopathy, or give wine, alcoholics, heroin, and garlic over the pillow in Sicily, in the region of Sicily. They put the garlic over the pillow in order to let the child fall asleep. But anyway, this is what parents can do, and for sure they are wrong. But what we suggest is that some behavioral techniques that are related to specific techniques like extinction, gradual extinction, positive bedtime routine, positive reinforcement, scheduled awakenings, preventative education, etc. But all these techniques are based on some assumption that the early childhood insomnia is strictly related to parent-child interaction at bedtime, and the seeking behaviors positively reinforce the problem of the child, because the parents' soothing behavior reinforce the problem in the child. So we should change parental soothing methods and the removal of the reinforcement. And this is the main focus of the intervention of behavioral techniques. But we should take into account that parental resistance is the biggest obstacle to implement intervention, because most parents find extinction or these techniques too stressful, since they are still sleep deprived and they are so stressed to implement this technique. But if we look at what the famous pediatrician think about sleep problem, we could have two different approaches. For example, Benjamin Spock says that the cure is simple: put the child to bed, close the door, and do not enter anymore in the room. And the Ronald Illingworth was from UK. He says that treating sleep problem is not simple. Phenobarbital is useless. The drug is chloral hydrate, that is no more used for important side effects. And for early awakenings, they say that at age 3, he must understand that should not disturb the parents, but before the age of the reason, one must accept this behavior as one of the penalties of having children. So nothing specific to do. Nothing specific to do because at that time the knowledge about sleep was not so important and so deep. So after the application of behavioral techniques, we know that there are some interventions that might be useful, like extinction, gradual extinction, or positive reinforcement, or preventing education of the parents. So with some techniques we could improve sleep. So this is an example of the several emails I receive. See, this child wakes up 3 to 6 times per night for drinking or requiring attention. several techniques. He doesn't not sleep an entire night since his birth. I lose weight, the mother, and begin to have insomnia and need drugs to sleep. My husband leave home for works and for sleeping better as soon as he has the opportunity. And the babysitter maid from Philippines resists because we are offering more and more money, but I think she will leave our home because they are also deprived. So after the graduated extinction, now we are celebrating the first week of uninterrupted sleep of my son Antonio, sleep 11 hours. I want to say that your system, I suggest a more easy approach and less stressful approach. The system is softer than the other described in books, allowing me to be calmer and feel less guilty. And for sure, this day was received from my son. Okay, so this is the one example of graduated extinction, but we could also have some children that have difficulty falling asleep, and oblige the parents to stay in all the night with him or with her in the same room. This is a case that this boy needs the presence of the father to fall asleep. If I move, he wakes up and asks for my presence. So it is 2 years that I have to stay in the bed of my son and even sleep all night in the chair or in the bed in his room. The problem is that he always needs my presence to fall asleep, and this is actually limiting his activities like summer camps or sleeping in a friend's house, etc. This is becoming a very big problem, and there is a concrete risk that the marital relationship will end. What should I do? So I suggest another technique that is named positive reinforcement, that is to giving some reinforcement in order to obtain the desired action. So this is the answer. 3 months ago, I contacted you. I apologize for this long delay before thanking you, but be sure I do still find very hard to believe that a problem that I consider very serious has been solved with the method that you have suggested. The conquest of an autonomous falling asleep had to have a purpose, which in my case was identified in a sum of money. So this father pay the son for letting him fall asleep. So we don't know how much money he spent, but he solved the problem. And but we also consider that there are some limitation of behavioral therapy. Limitation of behavioral therapy is mainly the parental resistance. And then if we look at objectively what happens after the behavioral treatment, what happens is that we have only a small increase of sleep duration and no evidence for reducing night wakes during the night. So this means that probably the child learned to fall asleep alone, but still wakes during the night. So we are not solving exactly the problem of the child. We are solving the problems of the parents. The parents are very happy because they fall asleep, but the child is still waking during the night as before. So no changes or no sleep changes using objective method like actigraphy. So if we think that not all behavioral treatments may be effective, then we could rely on a pharmacological approach. And we should think that there are no FDA-approved medication for insomnia in infants and children, that the medication might help the parents and children, and we could improve the symptoms instead of completely eliminating them, reassure parents, avoid abrupt suspension. And I think that we should not wait, because if we have a chronic insomnia, it's more difficult to change the habits and to improve the sleep of the child. But always should be associated a pharmacological treatment with a behavioral treatment. So you know that the pharmacological treatment, as you can see here, is very widely used. In 71% of preschool children with severe sleep problem, a pharmacological treatment has been prescribed. 35% of prescription under 1 year of age is for sleep problems. So the pharmacological treatment is very widely used, and but if we ask to the doctor which kind of treatment you prefer and which is the rationale for choosing a specific treatment, then over 40% indicated that they were uncertain to which sleep promoting medication would be the best choice. So they use melatonin, antihistamine, pain reliever, herbal preparation, etc., etc. So there are different kind of therapy or pharmacological therapy or over-the-counter treatment that may be used. But also we made a survey as well as in the United States that showing that the drug treatment is very widely used from about 60% of pediatricians and child neuropsychiatrists. And the most widely used are antihistamines, followed by benzodiazepine, imidazopyridine, etc. But also from very widely used are herbal infused or phytotherapy, as well as in the United States. So at that time, we do not have in Italy in 2004, we do not still have melatonin widely used in Italy. So we don't have melatonin in this survey. So if we approach to treat insomnia with the pharmacological treatment, we should be sure which kind of treatment, because if we go into personalized treatment, we should clearly identify which is the best treatment for the specific child. And for this reason, the global classification of international classification of sleep disorder promote a generic approach to insomnia therapy that failed to benefit some insomnia subgroup. And extremely important, in my opinion, is that insomnia is related to specific genotypes that act since early infancy and childhood, and that family history is the second strongest predictive factor for insomnia. And the heritability of insomnia is about 60%, even in adults, and also 30 to 40% in children. So we should consider that heritability is an extremely important point. And the genetic is extremely important. So when I approach a sleep problem in a child, especially insomnia, I always evaluate the family history to verify the genetic predisposition of insomnia. And we need to typify insomnia phenotypes with specific questions based on common parent descriptor. So we made this study. I retrospectively look at the charts of about 400 children that comes to my office for insomnia, and I defined the 5 descriptors of insomnia that are difficulty falling asleep, difficulty falling asleep with restlessness, nocturnal restlessness, early morning awakenings, and multiple night awakenings. After a latent class analysis, we identified 3 specific classes of insomnia. The first class is difficulty falling asleep with restlessness. The second class is the early morning awakenings, and the third class is the difficulty falling asleep and night awakenings. What is extremely important to know that the family history was completely different from these 3 groups. The first group has family history for restless leg syndrome and iron deficiency anemia. The second group is a family history for depression and mood disorders or migraine. And the third group has a family history for food intolerance or allergies. So this is an example of the first class. You see, this is the same child at different ages, and they have several admission to the hospital. And you see that they always this child moved a lot during the night. Even during daytime, was not able to stay still for a long period, just for a few seconds, and then make always the same movements and with slapping with the hand on the leg. So he probably have a sort of restless sleep because, and you see here the same, because of some unpleasant sensation in the legs, like the restless leg syndrome. But at that time, the main problem was insomnia, was not restless sleep, was insomnia. So this has been classified as insomnia and even classified as behavioral insomnia. But probably the presentation is different. And you see again this, and this also this girl has the same unpleasant sensation. You see this child that rub the legs always. Oh, sorry, that is always rubbing the legs, and this this need the message from the parent, from the father, in order to relieve the pain in the foot and in the legs. And you see that the father is yeah. So in order to relieve the pain of the unpleasant sensation, the father need to massage the foot and the legs of the child. But as I mentioned before, this when you make the diagnosis of restless leg syndrome in school age, in example, the same child in the first years of age were diagnosed as insomnia. So what we call hypermotor insomnia probably is a precursor or of a restless leg syndrome. So, and we have already mentioned about the treatment of restless sleep disorders with iron. And you see that the iron is connected with insomnia. In several studies show that nocturnal hyperactivity and nocturnal awakenings are related to iron deficiency anemia. And there are several studies that early insomnia is precursor of restless leg syndrome, and there is a correlation between iron deficiency anemia, insomnia, and restless leg syndrome, especially in children with ADHD. So this is why, because the iron is a cofactor of L-tyrosine hydroxylase that converts tyrosine in L-dopa and then dopamine. So if you have low level of dopamine in the brain related to iron deficiency, then you move a lot in the night and you have a hypermotor, what has been called hypermotor insomnia. So and this is another email I received. I am a mother of Georgia and Christian and Eduardo. My daughter Georgia started sleeping about 4 years. She always slept very little. Now I have the same problem with the other twins. At 3 months after the diagnosis of hypertonia, we did various tests, and the diagnosis was Sandiford syndrome. They wake up after 40 minutes, continue throughout the night, wake up 4 or 5 times for the night. Often while sleeping, they start to stretch a leg, the respective ankle and foot. Obviously, this causes awakening and crying. That is why I think it's not just reflux that disturbs the sleep. That's for allergy. In pregnancy, I suffered from restless leg syndrome, and that's a mild symptom tonight. I thought they could have the same thing, but it is possible in such young children. So yes, it is possible, because this is a very interesting paper in which these authors found that some children described as restless sleepers with the insomnia are diagnosed with behavioral insomnia of childhood. Behavioral modification therapy is recommended with the variable degree of success. They describe a 2-year-old with symptoms of restless sleep, bedtime resistant data sleepiness. that have underlying iron deficiency and treat successful with iron infusion. So based on this article, we say that what is considered behavioral insomnia of childhood problem, if we look exactly at what is the meaning and the significance of the symptoms of insomnia, then we could say that this is not a pure behavioral insomnia, but is related to some modification that are related to iron deficiency. So we use iron in hypermotor insomnia with ferritin level below 50 nanogram per milliliter, with the family history of restless leg syndrome and iron deficiency anemia, commonly 3 milligram per kilo, and for 3 months. So it is extremely important to, and I solve some problem of insomnia just with iron. Then we go into the class 2. Dear Dr. Bruni, in November, you helped me for the sleep problem of my son that had awakening and stay awake for 2-3 hours, so early morning awakenings. The problem is now Sister Lisa has the same problem. What should I do? Am I mother condemned not to sleep? I suffer from a headache and feel very tired. So this is a case of a second class with early morning awakenings, in which there is a family history for the mother and parents of the mother that are with depression, panic attacks, and migraine. So in this case, we could use 5-hydroxytryptophan. We prefer to use 5-hydroxytryptophan because it's involved only in the pathway of serotonin and melatonin, and not in the pathway of kynurenine like L-tryptophan. So if we should choose a specific drug or over the counter, we should use 5-hydroxytryptophan because it's more selective as the action. Commonly, we use 2 to 5 milligram per kilo before bedtime and for 2 months. And the third case is another example. Andrea suffered with left problem with the severe colics and had the gastroesophageal reflux. He has problem in falling asleep, continuous awakening. We try to extinction. We try with extinction, cry for 40 minutes in the first night and 70 minutes continuously in the second night. So we gave up. And this child had milk allergy, but also allergy and also family history for allergy. So in this case, we should use antihistamines. Antihistamines that are used in difficulty falling asleep and multiple awakening, especially in children with family history of allergy, and if the child, especially if the children have atopic dermatitis. Typically, the dosage is 1 milligram per kilo, and we have different kind of antihistaminics. Better to use the old antihistaminics that have a high affinity for H1 receptors of histamine. And this is a acceptable choice for parents, and they are useful for this kind of insomnia. So in order to summarize, we wrote this paper in which we define the 3 different kinds of insomnia that are related to the dysfunction of the specific neurotransmitters. So for dopamine, we use iron. For serotonin, we use tryptophan. For histamine, we use antihistaminics. So this is extremely also important to know. But also the vitamin D could be a way in which we could treat insomnia in children, because the first description by William Osler of vitamin D deficiency was that the presence of nocturnal restlessness and profuse sweating about the head and the neck. So if you have a child, and it's common that in early childhood you have profuse sweating and the nocturnal restlessness in this child, then you could consider that that child could have vitamin D deficiency, because vitamin D is a global epidemic, And vitamin D regulates the conversion of tryptophan and also has a crucial role in the dopaminergic system, and extremely important infant diagnosis with iron deficiency anemia simultaneously show low levels of vitamin D. And iron deficiency probably induced dopaminergic dysfunction via vitamin D deficiency. So we could associate iron and vitamin D in some subjects. Commonly 2,000 international units in the morning for at least 3 months of vitamin D, because if we have hypermotor insomnia with hyperhidrosis, then you could give vitamin D, and we wrote this review on the role of vitamin D in sleep disorders in children. So finally, just to let you know that melatonin is very widely used, and there was a great increase of the use of melatonin in the last years, especially in the older children and adolescents. And it's the second most prescribed drug in child psychiatry after methylphenidate. So most 85% as co-medication. So there was a great increase of use of melatonin. And we made in 2015 this recommendation for pediatric neurology. That is, we showed that the best efficacy was in sleep onset insomnia and delay sleep phase syndrome. And many children with neurodevelopmental disorder benefit from melatonin. The effect is in sleep onset, in reducing sleep onset latency and in increased total sleep time, but less efficacy on night awakenings. But the two important point is that melatonin does not affect sleep architecture, and no serious adverse effects have been reported in humans. Actually, there is a pediatric prolonged release melatonin for children without Smith-Magenis syndrome that are useful for improved sleep and sleep maintenance also in children with autism spectrum disorders. There is a safe, high compliance, and you see that there is an increase of total sleep time, a decrease of sleep latency, increase of longer sleep duration, and in the long term, also decrease of night awakenings. So melatonin should be used at typically 1 to 3 milligram in the night, but as chronobiotic should be given in the afternoon, 5 to 6 hours before the desired fall asleep. So and this is I think it's an extremely important paper, because it gives a picture of how melatonin is used. You see, for example, that for children, very young children, the most prevalent prescriptors are pediatrician, while in the older ages, the child psychiatrists prescribe melatonin more. So, and another important point, that the group that were more adherent after 1 or 2 or 3 years are the group of 6 to 12 years old and 0.5 years old. You see that when they start to take melatonin, they continue at least for 3 years in a high percentage of cases in school-age children, and also in very young children. So they continue to use for a long time to take melatonin. And finally, if we do not have any success with all this treatment, then we use the old treatment of our grandmothers and grandfathers, especially in South Italy. The grandmother used the Papaver somniferum plant. It's the opium poppy that is cultivated in the peasant world in Italy in the early 20th century, and used it in form of decoction as sleeping pill, painkiller, and tranquilizer. The dear grandmothers of the South Italy basically administer alkaloid-based remedies to their grandchildren. And the little ones, they could also use opium for colic. So in like utitilo, a sort of pacifier made from piece of linen rolled up and dipped in this decoction of opium. But this is not really has been used laudanum. Laudanum is the opium preparation with wine and alcohol and various adjuvants. So you see that there was an advertisement: sleepless baby use laudanum. So this was used in also in the last century for sleepless baby, and opium was used a lot even in newborn for over 3 millennia, and in 1912 was the legislation prohibited the cultivation of the opium plants because of several cases of death in the children. So thanks for your attention. I hope to stay on time. Thank you.
Thank you so much, Oliviero. So as always, for your enlightening talk. So I'm sure everybody will have got plenty of ideas and plenty of questions. So I really would like to thank each of the speakers for their time, willingness to share their knowledge freely. And I hope that these talks have provoked a lot of reflections and questions. So I'm gonna open up the chat box and see if there are any questions. I've tried to do my best in between the talks, but I know there's still plenty of people present. Does anybody have a question or remark or reflection? If not, I'll shoot one in terms of, because I've heard in all three talks, misdiagnosis, comorbidity, co-occurrence. And so what should we do? What should be our next step in terms of, improving this diagnosis, or what should we do as a very open and question? Don't know if Silvia or Oliviero, you have thoughts on that? Because each of your talks really mentioned insomnia is so prevalent. So what should we do then?
Yeah, what I would say is the most important point to try to identify the specific phenotype. This is in line with the trend of research right now that is going more and more into personalized medicine. So if we identify phenotypes, then we could improve the treatment of insomnia and improve the treatment of several disorders. So this is, in my opinion, extremely important to clearly identify, especially, for example, in Italy, insomnia is considered as a let's say, as a mysterious symptoms from pediatrician, because they only give melatonin, and they do not take time in order to clearly understand the specific type of insomnia, or try to understand which is the family history for the child. And I think that in my clinical experience let me understand that the family history and genotype are extremely important, because especially in early age we could have the importance of genetic factors is more strong than the epigenetic factors, because the epigenetic factors act during the life. So in the early ages, the other is most important, the genotype, other than the epigenetic factors, and this is my opinion based on my clinical experience. So
and how we evolve. Silvia, you have any thoughts about that in terms of the imaging data?
So no, I was thinking in the last time, and also discussed with Oliviero, that we should increase the awareness and knowledge about pediatric sleep medicine in general, and in particular of insomnia, because many pediatricians can cover this kind of topics without any experience. So this is the reason why it is important to organize such kind of webinar, but also we should maybe increase our visibility in social network, because you know that social network can do many good things, but also bad things. If you think of pandemic with fake news, with many expertise on many topics, and also insomnia can be covered by people that does not any qualification or experience on that, and maybe we should increase our visibility. I'm embarrassed to do it because I used to stay in the sleep lab alone, studying, etc. So doing something like this is not easy for us. And for instance, Oliviero, many years ago, employed a blog that was not a big idea to increase the visibility, and not only for helping parents. So maybe we should start also in the sleep society to increase this kind of tools.
Yeah, for sure. In Italy, for example, we have a lot of on the Instagram, a lot of sleep consultant without any experience. So they say that they are certified sleep consultant, but we don't know who certified this.
Without any control.
Yeah, without any control, and they earn also they earn a lot of money with this, because they made a lot of consultation and etc., online consultation, and so without any specific knowledge, as
sort
far as I know.
Babysitter for insomnia.
Exactly.
Yeah.
They consult,
Yeah, so
and they
yeah, go ahead. So it is indeed, I think, a risk of insomnia disorder, that it is so common, so accessible, but then so little expertise to refer to and to properly address the roots of the problems. And I hope that this webinar, and that's also the reason to hold this webinar, demonstrated how comprehensively insomnia should be assessed, and how these complaints can be transdiagnostic. Yeah? So we saw it, autism, ADHD, iron. So there's a lot of elements here that need specialized attention, and that is occurring in typically as well as in atypically developing children. And I think also
Karen,
each of our talks, yes?
there are some questions.
Yes. So that's what I was getting to, because each of your talks also addressed the aspect of age. And so age is, especially in neuropsychology, very important. And so those questions came. So can we link, in terms of the phenotypes that have been discussed, the neuropsychological comorbidities to that, particularly for the ADHD model, because that's really advanced neuropsychological models. So Sylvia, do you know any responses?
Oh, I was thinking this is a complex question, but I think that ADHD can is a model, because sleep disorder induce attention deficit disorder as a consequence of chronic sleep deprivation. So it can be a sort of mimic. So it is important to distinguish what is secondary and what is primary. But if you look to other new disabilities, such as autism, there are also in autism an overlap with ADHD, and also there is many evidence about melatonin alteration and other comorbidities with epileptic on discharges, and maybe we can start also to phenotypes sleep disorder in autistic children, because sometimes it's not simply insomnia in relation to melatonin, but you can have other complex sleep disorders, and this is something that should be investigated more. There is a gap in reality, and maybe also the hypothesis that some of them may suffer restless syndrome or iron deficiency is under investigated in autistic children. While in other neurodisabilities, also actually there are data, because you can have comorbidity with always obstructive sleep apnea, such as in Down syndrome, and in reality, maybe we should write some guideline about not only consider sleep disorder simply insomnia in children with neurodisability.
Yeah. Thank you. Yeah, guidelines are really needed, and also to address this consultants issue, I think. And then the other question was, Oliviero, I think already answered in chat, but that was, where can we find recommendations for this differential diagnosis according to medications? So that is another question. So
Yeah.
Oliviero.
Yeah. I just put on the chat the reference for the paper that is Chronic Insomnia of Early Childhood Phenotypes and Pathophysiology, that has been published in Neuroscience and Biobehavioral Reviews in 2022. So this is a comprehensive review on phenotypes that I presented here. So it might be helpful if you want to go deeply into this topic.
Okay. And yeah, I have a couple more questions because
yeah,
we are
there's another
getting
question
over time.
about what
environmental
screen in
yeah.
ADHD. This is something I was thinking about a lot, because I was really disappointed, but also for the sample size, that I did not find any red flags for distinguish ADHD with epileptic on discharges from the other. Because I found some red flag for the other sleep phenotypes, but any differences in these children. So the answer should be, you should record and do a polysomnographic recording in all children with ADHD, but this is not possible to do. It's very expensive. And I suggest at least to perform a brief sleep EEG recording in these children, not simply a wakefulness EEG.
If I can add something, Sylvia. I see, you know, that actually there is more and more the identification of preschool ADHD. So for preschool ADHD, I found very useful to collect blood sample for iron, because
yes,
most of these children
we already done. So this was already. Yes, but that was not the question, because he already done the blood sample in the routine, Dr. Alexander Dueck.
Yeah, but I think that this is extremely important for preschool age children that has ADHD. That was my point of discussion. No, not. So and I found it very useful, and they improve a lot just with iron, without any other drug like methylphenidate or other things. So
there's also one short question, and then we'll round up, I think, because we're getting over time. And so about the treatment of environmental insomnia elicited by abuse of technologies. So any comments or reflections on that?
Yeah. So This is more related to not to early childhood, but especially in for school-age children and especially adolescents. So this is the environmental insomnia, to treat environmental insomnia related to technology. My experience is that you should alert the adolescent for a motivation. If he is motivated to improve his habits, so most adolescents, for example, abandon the school because they were no more able to go to school because they stay all the night with the smartphone or consoles or any other or chatting or social network, etc. So the first point is the motivation of the adolescent to change the habits. Second point is the increase the sunlight exposure. And I often suggest not to close the window, but let the sun to enter into the room in the early morning. And also I suggest a bright light in the morning, and melatonin as chronobiotic, meaning that you have to give a small dose of melatonin in the afternoon, 5-6 hours before the desired bedtime, and then another 3 milligrams of melatonin at the time of falling asleep. So that's my suggestion. And the bright light is extremely important. And most important point, the only thing for which there is a scientific evidence is that the physical activity improved the circadian rhythm of the adolescents. So suggest all the adolescents that have this problem to increase the physical activity and to make sports during daytime in order to set the circadian rhythm. That's the, and obviously the parental control over the overuse of the technology.
Okay, thank you very much. So I believe that we can agree that sleep is essential, and this particularly in childhood, and that careful assessment, that the diagnosis, as we presented in these talks, these are crucial steps towards a successful treatment. And so that these talks further demonstrated that although insomnia complaint might have different roots, I think it has a detrimental impact on the family's sleep. We cannot ignore that. So, and as Oliviero showed it with the emails of the parents, at least one parent will have poor sleep when they struggle each night with a poor sleeping child. So, and Sylvia mentioned it, an increased awareness, I keep saying it, across all healthcare professionals is a priority of our discipline of pediatric sleep field. And I believe that it should resonate across our society, as the last question already mentioned. So for those that have tuned in later on during the talks, a replay will be available about 1 or 2 weeks after this closure of our webinar. So I would like to thank MDPI for taking the first step in this webinar for the topical collection, Sleep in Children. I'm very grateful for that. And so I also thank everybody for listening and for sharing in your networks, I hope, the sleep knowledge, the important sleep knowledge that was gained today. And I look forward to seeing you all in our next webinar. So thank you very much all.
Okay, thank you. Thank you,
Bye.
bye.
Bye-bye.
Bye.